Good morning, doctors. Today we are on our 28th day of reading Oxford Handbook of General Practice. I'm Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. So we were at page number 523, reading about other movement problems. Let's start reading. Dizziness and giddiness. Distinguishing between true vertigo, the illusion of rotatory movement, the room spinning, and the feeling of unsteadiness or lightheadedness. Vertigo will be discussed in page 928. Imbalance implies difficulty in walking straight. Example from disease of peripheral nerves, posterior columns, or cerebellum. Faintness, the feeling of about to pass out, associated with some seizure disorders and variety of non-neurological conditions. So faintness, examples of faintness are postural hypotension, vasovagal syncope, hyperventilation, hypoglycemia, arrhythmias. Sometimes more than one element coexists. Transient loss of consciousness. Transient loss of consciousness in the back in the form of blackouts, faints, and funny turns is a common presentation to general practice. Funny turns in small children. 874. We will see the history. You have to take a good history from the patient and ideally ask for a witness too is essential to establish the correct diagnosis. Ask, did the patient lose consciousness? Quite frequently, the patient describes episodes of dizziness or unsteadiness or falling as funny turns. Does the patient remember the whole episode? If not, which bits are missing and how long are the gaps? What happened before, during, and after the event? What is the duration of the event? When and where did it happen? Posture at the time of the event, whether patient was standing, sitting, lying. Did it start during sleep? Were there any precipitating events? Were there any warning signs? Example like an aura, feeling going to faint, sweating, feeling hot, visual disturbance, etc. Did the patient jerk his or her limbs? If so, was the jerking generalized or restricted to one area of the body? What did the patient look like? Eyes open or shut, color? Did anything else happen, like tongue biting or incontinence? What happened after the attack? Was the patient conscious straight away? Was there a disorientation or confusion, drowsiness, weakness down on one side? Also check general medical history including cardiac history and history of other neurological symptoms, medication, example diuretics TCS, psychiatric history, anxiety, depression, panic attacks, family history, any family history of epilepsy or cardiac arrhythmias, substance abuse, drugs or alcohol. Examination. Usually normal by the time the patient is reviewed by a GP. Check the temperature, respiratory rate, pulse and BP lying and then standing for 3 minutes. So you have to check the BP in lying down position and then standing position for 3 minutes. Listen to the heart. Record any neurological deficit. Investigations. A 12-lead ECG immediately or in less than 3 days. Consider checking capillary blood glucose if diabetes and FBC if any suggestion of bleeding is present. Significant ECG changes. Any ventricular arrhythmias, including ventricular ectopics, long QT syndrome more than 450 milliseconds or short QT syndrome less than 350 milliseconds. Brugada syndrome is covered ST segment elevation, coved ST segment elevation more than 2 millimeters in more than one of the V1, V2, V3 leads, followed by a negative T wave, which may be transient. So Brugada syndrome is a coved ST segment elevation with more than 2 millimeters in more than one of the anterior leads. Ventricular pre-excitation. It's a delta wave or slurring slow rise of the initial portion of the QRS complex seen in WPW syndrome. Delta wave seen in WPW syndrome. Uh, inappropriate significant bradycardia, pathological Q waves, left or right ventricular hypertrophy, abnormal T wave inversions, sustained atrial arrhythmias, or paced rhythm. Management: treat any underlying identified cause. Admit: if any residual neurological deficit is there, you have to admit to exclude a stroke. Refer to cardiology for assessment. If less than 24 hours, within 24 hours, for if there is any abnormality on ECG, there is heart failure, clinical or history of heart failure, transient loss of consciousness during exertion. When it is during exertion, family history of sudden cardiac death less than 40 years or inherited heart condition. This is in lines of HOCM. Transient loss of consciousness during exertion or family history of sudden cardiac death. This points towards HOCM. If there is a heart murmur, if there is new unexplained breathlessness, consider referral if more than 65 years and transient loss of consciousness without prodromal symptoms. So if the patient is more than 65, then you have to think in terms of transient ischemic attacks. So transient loss of consciousness is that without any prodromal symptoms, still you consider referral. Refer urgently to neurology if inexplicable gaps in recollection of events is present, a prodromal deja vu or jamais vu, tongue biting, unusual posturing or head turning to one side or a prolonged limb jerking during the event. A brief seizure-like activity can be associated with simple faints. Confusion following the event. So these all. So if you are thinking it is epilepsy, and if any of these symptoms are present, you need to urgently refer to neurology. And you have to consider referral if you are thinking in terms of transient ischemic attacks. And if it is HOCM, you have to refer to cardiology for assessment if within 24 hours or any arrhythmias. Epilepsy is less likely if prodromal symptoms are recognized by the patient and on previous occasions have been elevated by sitting. Less likely if there is any prodromal symptoms, then it is not epilepsy. And a patient has recognized this on previous occasions and has been elevated by sitting or lying down. The episode was precipitated by prolonged standing or there is sweating before pallor or pallor during the episode. So this is with vasovagal syncope. So prolonged standing or there is sweating or before or after pallor during the episode, then epilepsy is ruled out. Refer for routine. Refer for routine cardiology review. If urgent referral is not indicated, then no cause identified. If urgent referral is not indicated or there is no cause identified, then the episode was atypical for a simple faint, situational syncope, or orthostatic hypotension. If you are not thinking in lines of simple faint, situational syncope, or orthostatic hypotension, refer the patient for routine cardiology review. If no other causes identified. Vasovagal syncope, simple faint. The peripheral vasodilatation, bradycardia, and venous pooling. Postural hypotension. Vasovagal syncope, simple faint. Peripheral vasodilatation, bradycardia, and venous pooling leads to postural hypotension. More in females than in males. Diagnosed if no feature suggestive of alternative diagnosis is present, or any of these three P's are positive. Posture. Prolonged standing before the event or similar episodes in the past that have been prevented by lying down, pre-syncope. Provoking factors, pain or a medical procedure. Prodromal symptoms, sweating, feeling warm or hot before the event. Situational syncope, provoked by straining during micturition or when the bowels open, or coughing, or blowing or swallowing. Management, reassure, no treatment is necessary. Orthostatic or postural hypotension, we have already read in 217. Hypoglycemia, Affects patients with diabetes taking insulin or oral hypoglycemic agents. Produces autonomic changes, pallor, sweating, tachycardia, and behavioral changes, confusion, altered personality. If action is not taken to increase the blood sugar, coma plus sweating or coma, if action is not taken to increase the blood sugar, then can lead to coma and fits ensues. Epilepsy, dizziness or giddiness, hyperventilation and panic attacks. 1081. Usually history is diagnostic, but temporal lobe seizures may have similar symptoms to that of hyperventilation and panic attacks. Abnormal perceptions, hallucinations. We will read all of these topics in the appropriate pages. Assessment of headache. A common presenting complaint. The skill lies in deciding which headaches are benign, needing no intervention, and which require action. History. Is there any type 1, more than one type of headache? Take a separate history for each. Time. When did the headache start? How often do they happen? Is there a pattern? Constant, episodic, daily? How long do they last? Why the patient is consulting now? A headache diary over more than 8 weeks may be useful in long-standing headaches. Character. Nature or quality of site of pain. Associated symptoms. Example, nausea, vomiting, visual or neurological symptoms. Cause. Predisposing or trigger factors, aggravating or relieving factors, relationship to menstrual cycle and family history. Response. Details of medication use, type, dose, frequency, timing. What does the patient do? Example, can the patient continue to work? So, whether during the headache the patient can continue to work or has to stop working. Help between the attacks, other medical history, between attacks. Patient's anxieties and concerns regarding the headache. Examination. In acute severe headache, examine for fever, purpuric rash. In all cases, check the BP, brief neurological examination including the fundi, visual acuity, gait, palpation of the temporal region, sinuses for tenderness and examination of the neck. Or sinuses and tenderness and examination of the neck. So this is for acute headache, severe headache with fever. So headache, then you need to examine for fever, purpuric skin rash. In all the cases of headache, you have to check the BP, do a brief neurological examination including checking the fundi, the visual acuity, gait and palpation of the temporal region, sinuses for tenderness or examination of the neck. So temporal arteriitis if it's there or sinusitis. In young children, measure head circumference and plot on a centile chart. Refer to an appropriate specialist team. Emergency or urgent, soon or routine. When there is fever and worsening headache, plus a purpuric rash plus meningisms. Fever, worsening headache, purpuric rash, meningism. Emergency referral. Decreased consciousness and or papilledema. Emergency. Thunderclap headache, reaching a peak intensity in less than 5 minutes. Emergency. New onset seizures. Emergency or urgent. Recent head injury less than 3 months. Emergency, urgent or soon. Change in personality, new cognitive or neurological deficit. Consider referral for direct access MRI or CT in adults and specialist assessment less than 48 hours in children. So if there is new personality changes or cognitive or neurological deficit, then you consider referral to direct access MRI or CT in the adults, but in children you need to consider specialist assessment in less than 48 hours. This concept has been tested again. New onset, unexplained persistent headache in a patient with a history of HIV, immunosuppression, or cancer metastatizing to the brain. Suspected, there's you need to do an urgent referral. Suspected acute glaucoma for ophthalmology review. Suspected temporal arteriitis for temporal artery biopsy. Progressive headache worsening over the week, especially if associated with vomiting, drowsiness, coughing, sneezing, or exercise. Urgent or soon referral. Atypical migraine aura plus headache. Example, motor weakness, double vision, visual symptoms such just in one eye, poor balance, decrease in consciousness, urgent referral, substantial change in quality of usual headaches, urgent or soon, persistent headache for more than 1 month, or frequent headaches despite treatment affecting usual functioning. So this is medicine dependent headache. So this also soon or routine referral. Differential diagnosis and management, table 15.8, we can check, we will see. Rise in BP may cause an acute or chronic headache. High BP may cause acute or chronic headache. Direct treatment at the cause. Direct the treatment at the cause. Differential diagnosis of headache. Acute new headache can be migraine. An acute new headache can be meningitis. Meningitis will have fever, photophobia, stiff neck, and a rash. IM or IV penicillin B, an immediate admission is required. Encephalitis. Fever, confusion, decrease in consciousness level. Immediate admission is required. Subarachnoid hemorrhage. Even meningitis and encephalitis. In encephalitis, there will be confusion and reduced consciousness level. Okay, immediate admission there will be. In meningitis, only photophobia and stiff neck. Subarachnoid hemorrhage. This is a thunderclap headache or very sudden onset headache plus a stiff neck. So a thunderclap headache and a stiff neck due to meningitis due to the blood irritating the meninges. Immediate admission. Head injury. Bruising or injury and decrease in consciousness level and periods of lucidity, amnesia, consider admission. You need to consider for admission in a head injury case. If there is any bruises or injury or decrease in conscious level and periods of lucidity or amnesia. Self-limiting viral illness. Vary. Often associated with other symptoms like coryza, sore throat, low-grade fever. Give a paracetamol, NSAID and review if worsens or not in a setting in 2 to 3 days. Sinusitis. Tenderness over the sinuses plus a history of upper respiratory tract infection. Manage accordingly. Dental caries. Facial pain and tenderness will be there, then manage accordingly. So tropical illness, history of travel or fever, acute recurrent migraine headache. Uh, if it is acute and recurrent, then it could be migraine. Aura, visual disturbance, nausea, vomiting triggers will be there. Cluster headache, nighty pain for one eye for 2 to 3 months and then pain free for more than 1 year. Exertional or coital headache, suggested by a history of association, NSAID or propranolol before the attacks. Trigeminal neuralgia, intense stabbing pain lasting seconds in the trigeminal nerve distribution. Glaucoma, red eye, halos, decreased visual acuity and pupil abnormality. So whenever the headache is because of glaucoma, acute and episodic, red eye, you will find red eye, halos around the eye, reduction in visual acuity and pupillary abnormality, that is mid-dilated pupil and fixed. Subacute headache, giant cell arteriitis, more than 50 years. You have to check whether the age is more than 50 years. There is scalp tenderness, increase in ESR, rarely decrease in visual acuity. So trigeminal neuralgia, intense stabbing pain lasting seconds in distribution. There was some provoking is there whenever you trigger a particular area, like tap on a particular area, you can generate the pain in the trigeminal neuralgia. Whereas subacute headache, giant cell arteriitis, you can see only more than 50 years and there is scalp tenderness and there is increased ESR and rarely a decreased reduction in visual acuity. This is temporal arteriitis or giant cell arteriitis, a type of vasculitis. Chronic headache, tension type headache, a band around the head, stress and low mood. Cervicogenic headache, unilateral or bilateral band from neck to the forehead. So the band is not horizontal like in tension headache, it is vertical, a band from the neck to the forehead and scalp tenderness will be there. There will be scalp tenderness. This is cervicogenic headache. Medication overuse headache, rebound headache on stopping analgesics. Increase intracranial pressure. The headache in increased intracranial pressure worsens on waking or sneezing and decrease their waking and sneezing, and there will be low pulse, high BP and neurological signs. increase intracranial pressure, low pulse, high BP, and neurological signs. Paget's disease. The headache in Paget's disease, chronic headache in a more than 40 years old with bowed tibia and increased alkaline phosphatase. Bowed tibia and increased alkaline phosphatase. Paget's disease, there will be remodeling. There will be increased bone turnover and bone remodeling, leading to this frequent changes in the foot size, in the shoe size, and frequent changes in the hat size. And again, there is this bowed tibia and increase in alkaline phosphatase. So next topic for discussion, page number 528, migraine. Migraine affects 15% of the UK population. Uh, Males more than female, so male to female ratio is 1:3. So females more than males. 1 in 3 experience significant disability caused by disturbance of cerebral blood flow under the influence of serotonin. Disturbance of cerebral blood flow under the influence of serotonin. Aura. Aura occurs with or without headache. Symptoms arise more than 5 minutes and last 5 to 6 minutes, 60 minutes before resolving completely. So this is one thing which has been tested time and again. Symptoms arise more than 5 minutes and last 5 minutes to 60 minutes. So within 1 hour, when it is, that is typical aura. And if the aura is lasting more than 1 hour, you have to consider transient ischemic attack or other neurological problems before resolving completely. So if more than 60 minutes the aura is present, you have to think of other diagnosis. Diagnose if there are visual symptoms like flickering lights, spots, lines, partial loss of vision. So see, partial loss of vision can be uh, a sign of TIA in the of transient ischemic attack or an aura. How do you differentiate that? If your partial loss of vision is lasting more than 60 minutes, you have to consider in lines of transient ischemic attack. Sensory symptoms: numbness, paresthesia, or speech disturbance. Atypical aura. Consider referral for further investigation if motor weakness, double vision, visual symptoms. If there Atypical aura is if you have motor weakness. Normally it's a sensory thing. Visual symptoms, sensory symptoms, speech symptoms. But if it is having motor weakness, double vision means paralysis of the extraocular muscles, weakness of extraocular muscles. Visual symptoms affecting only one eye, or poor balance, or a decreased level of consciousness during the aura. It is atypical. You consider further referral. Migraine headache. Moderate to severe unilateral or bilateral throbbing, pulsating headache lasting 4 to 72 hours. 4 hours to 72 hours, 1 hour to 72 hours in children, and prevents usual activities. May occur with or without aura and be associated with nausea, vomiting, plus or minus increased sensitivity to light and noise. So this is one of the diagnostic features of photophobia and phonophobia, diagnostic features of migraine. Episodic migraine occurs on less than 15 days of the month. Chronic migraine occurs more than 15 days in a month and over 3 months. History, examination and differential diagnosis of migraine, page 526. Management of an acute attack. So we have already read this differential diagnosis of different types of headache have been we already read in the table on page number 526. So we'll go to the management straight ahead. Management of an acute attack of migraine. Combination therapy with triptan. Sumatriptan 50 to 100 milligrams PO. Choice depends on the cost. Not effective if taken before the headache develops. Stop 70 to 85% of the attacks. So this is not supposed to be taken if taken before the headache develops. So not preventive or prophylactic. Stop 70 to 85% of the attacks. Starts with lowest dose and increase as needed. Start with the lowest dose and increase as needed. If consistently ineffective, try an alternative triptan. Consider nasal triptan as first line if age is 12 to 17 years. So this is one thing to remember. If patient is young, 12 to 17 years, try a nasal triptan is advice. NSAIDs, example naproxen 500 milligrams BD or paracetamol 1 gram QDS, 1 gram QDS plus an antiemetic prochlorperazine 5 milligrams or metoclopramide 10 milligrams or domperidone 10 to 20 milligrams even if no nausea or vomiting. Why? Because of its prokinetic effect. So because of there will be stasis in the bowel, and bowel emptying will be delayed. Bowel transit time is delayed. Any of these medicines, whenever you give the patient, it will not actually go for the metabolism in the bowel because there is bowel stasis. So what you will do, you will give a prochlorperazine, metoclopramide or domperidone along with the NSAIDs. This is not for preventing nausea or vomiting. This is for prokinetic effect. If all oral preparations are ineffective or not tolerated, offer a metoclopramide 10 milligrams PR or buccal prochlorperazine 3 to 6 milligrams, and consider adding a non-oral NSAIDs like diclofenac 100 milligrams PR or a triptan. Example, sumatriptan 20 milligrams nasal spray. So you have a 20 milligrams nasal spray or a 6 milligram subcutaneous injection. If oral preparations are ineffective or not tolerated, that is because of the delayed gastric emptying and delayed bowel transit time. So give him something that is either parectal, diclofenac, or something that is nasal spray or a subcutaneous injection. Do not offer ergot or opioids for acute treatment of migraine. Do not offer ergot derivatives or opioids for acute treatment of migraines. Treatment of recurrence within the same attack. So repeat symptomatic treatment within the dose limitations. Pre-empty 5 if recurrence is usual or expected. If using triptans, a second dose may be effective, but repeated dosing can cause rebound headache. Naratriptan and elytriptan are associated with relatively low recurrence rates. Management of chronic migraine. So within the same episode, if on the second day again the patient is getting a rebound headache, then you have to give another dose of triptan, but you cannot be repeating many doses. Aims to control symptoms and minimize impact on patient's life. Cure is not realistic aim. So trigger factors for the headache you have to decrease. What is the trigger factor for migraine? Half of them have a trigger for the migraine. Consider psychological factors like stress, relief of stress, anxiety, depression, extreme emotions, anger or grief. Environmental factors: loud noise, bright or flickering lights, strong perfume, stuffy atmosphere, video use, strong winds, extreme heat or cold. These are environmental triggers. Food factors: lack of food or infrequent meals containing food containing monosodium glutamate. This is more in the Chinese foods, and caffeine, MSU, MSG, caffeine, tyramine. Specific foods, example chocolate, citrus fruits, cheese, alcohol, especially red wine. So these are tyramine. See, when tyramine or tyrosine is present, then again it will lead to more serotonin production. So those specific foods like chocolates, citrus fruits, cheese will have a tyramine, and then alcohol, especially red wine. These will lead to increased production of serotonin, thereby trigger an attack of migraine. Sleep. Overtiredness, physical or mental changes in sleep patterns, example late nights, weekend lie-in, shift work or holidays, long distance travels. Health factors. Hormonal changes, example monthly periods, COC pills, HRT and menopause. These are the trigger factors for migraine. In high BP, tooth pain or pain in the eyes, sinuses or neck, unaccustomed physical activity are the health factors that can trigger a migraine. Assessing severity. Assessment scales, example Migraine Disability Assessment Scale or MIDAS, Migraine Disability Assessment Score, can be useful in assessing the impact of symptoms on daily life and monitoring response to treatment. General measures. Reassure. Instruct about the management of acute attacks. A diary can be used to identify trigger factors, assess headache frequency, severity, medication usage or overusage, and response to treatment. So, they have to maintain a diary to identify the trigger factors, assess the headache frequency, severity, medication usage, overusage, and the response to treatment. Like when they took the medication, did it Give them a response or not. Avoid the trigger factors when possible. Give an advice on relaxation techniques and stress management. Do not offer COC to women with migraine. So this is COC, combined oral contraceptive pill in a woman with migraine is UKMEC category 4, especially if aura is present. Prophylaxis. Consider if more than 4 attacks or per month or severe attacks are there, only then you have to consider prophylaxis. More than 4 attacks per month or severe attacks. Decrease the attacks by 50%. Try a drug 2 months before deeming it ineffective. So at least 2 months you have to try before you say it is ineffective. If effective, continue for 6 months, then consider decreasing dose slowly and stopping it. First line, propranolol SR 80 to 60, okay, standard release 80 milligrams or sustained release 80 to 160 milligrams OD or BD. Oh my god, it's a very high dose. And topiramate 25 to 50 milligrams OD or BD. Start at a low dose and increase dose every 2 to 4 weeks. Topiramate is teratogenic and may decrease the effectiveness of hormonal contraception. So, when you are giving topiramate, you have to give them a very good contraception. Give the patient very good contraception, not hormonal contraception. Second line, gabapentin. Up to 1200 milligrams per day in divided doses, or acupuncture up to 10 sessions over 5 to 8 weeks. Third line, consider referral. Botulinum toxin type A may be helpful for patients who have chronic migraine and do not have medication overuse headache and have not responded to more than 3 different prophylactic agents. Alternative therapies. Riboflavin 400 mg OD may decrease the frequency or intensity of the headaches. Fever few 200 milligrams per day may decrease the symptoms after 6 weeks of use. It is fever few. What is this drug? May decrease the symptoms after 6 weeks of use. Menstrual migraine. Suspect if migraine occurs from 2 days before to 3 days after the start of the period or at least 2 out of 3 consecutive months, use the headache diary. If predictable menstrual related migraine that does not respond to standard acute treatment, consider frovatriptan 2.5 mg BD or zolmitriptan 2.5 mg BD or TDS on the days that migraine is expected. So this is given for prophylaxis of menstrual migraine. Referral. More than one type of headache may be present. 50% migraine sufferers develop tension type headache. Consider each separately. Other headaches and facial pain. Headache assessment and differential diagnosis already we have seen. Migraine we have seen. Chronic daily headache. Prevalence 4%. Defined as any headache that occurs more than 15 days in a month. Common causes are tension type headache, cervicogenic headache, medication overuse headache. Yes, when you are using more NSAIDs for headache, then it will cause medication overuse headache. Migraine, errors of refraction. Usually headache is mild, frontal in the eyes themselves and absent on waking up. So when you wake up in the morning, it's not there. And then when you start accommodating or straining your eyes, then your headache will start. Treat the cause and maybe even if the cause is more than one cause, treat them separately. Tension type headache associated with stress, anxiety, or functional or structural abnormalities of the head and neck. Prevalence is 2%, near about 2%, and females more than males. Migraine, male to female is 1:3, so more in females again. And here again, females more. Symptoms begin aged less than 10 years in 15% of the patients. Prevalence decreases with age. Family history of similar headaches is common in 40% of the patients, but twin studies do not suggest on a genetic basis. Distinguish between episodic and chronic tension type headache. Episodic tension type headache defined as headache lasting 30 minutes to 7 days and occurring less than 180 days in a year, that is less than 15 days in a month. Chronic headache lasting on more than 15 days per month and more than 180 but less than 180 days per year for more than 3 months. In both cases, pain is bilateral, pressing or tightening in quality, of mild or moderate intensity, not associated with vomiting, not aggravated by physical activity, does not prohibit the activities. That means it is there. You have a headache, but it is not obstructing your daily physical activities. Whereas in migraine, it will obstruct your daily physical activities. It will have photophobia and phonophobia. That's how you have to distinguish between both. And it is bilateral and tightening and pressing type. That one, migraine is pulsating and mostly unilateral, can be bilateral also in children. Management, reassure no serious underlying pathology is present. Acute management, simple analgesia, example paracetamol, ibuprofen. Avoid codeine containing preparations under the opioids. Advise short-term use of analgesics only. At risk of medication overuse, headache or opioid dependence if analgesics are used long-term. So that's why not to give opioid, because they can lead to dependence. Try measures to elevate the stress, relaxation, massage, yoga, exercise. Treat musculoskeletal symptoms with physiotherapy. Consider for referral for prophylaxis with acupuncture if available, up to 10 sessions over 5 to 8 weeks. Cluster headaches. Extremely painful headaches focused around one eye with associated autonomic symptoms on that side, drooping eyelid, constricted pupil, red watery eye, runny or blocked nose. So these are all the symptoms of associated with a cluster headache. Drooping eyelid, constricted pupil, red watery eye, running or blocked nose, forehead sweating. Rarely less than 20 years of age. So tension headache starts in less than 10 years, mostly in 10% of the in a percentage of the patients. Where did this go? Hmm. And whereas cluster headache rarely less than 20 years, again male to female predominance, so more common in the males, 6 times more common in males, more common in smokers again. Pain lasts for 15 to 180 minutes, 15 minutes to 180 minutes, that is at least 3 hours, and occurs from one time every 2 days to 8 times per day. So recurrences affect on the same side of onset is often predictable 1 to 2 hours after falling asleep after alcohol. Two patterns are there: episodic remissions of more than 1 month, chronic remissions less than 1 month in 12-month period. Management, refer for a specialist advised neuroimaging or neuroimaging for the first bout of cluster headache. Drug treatments, acute attack, 100% oxygen, more than 12 liters per minute for 10 to 20 minutes. 5-HT1 agonist, example sumatriptan, 6 milligrams subcutaneous or 20 milligrams intranasal. Stop 75% of the headaches in less than 15 minutes. 5-HT1 agonist and 100% oxygen for 20 minutes. Prophylaxis, consider verapamil 80 milligrams TDS or QDS if attacks are frequent. Need ECG monitoring when you're giving verapamil because it is a rate limiting calcium channel blocker. Seek specialist advice if unfamiliar with use. More effective if initiated early and start of new cluster. So more effective if you're giving the prophylaxis early and at the start of a new cluster. Refer for specialist advice if no response to verapamil. Medication overuse, headache or analgesic overuse, headache. Persistent headache in patients with other causes of pain who are overusing analgesics. Effects in 1 in 50 adults, females more than males. Again, consider if headache develops or worsens when taking analgesic medication for more than 3 months. Implicated drugs include triptans, opioids, ergots, combination analgesics for more than 10 days in a month. Paracetamol, aspirin, NSAID on more than 15 days per month. Management. So medication overuse headache again is common in females, migraine is common in females, whereas tension headache is common in females, whereas cluster headache is more common in males. Management. Explain the condition to the patient. Advise stopping overused medication abruptly or at least 1 month. For at least 1 month. Provide follow-up and support over 4 to 8 weeks. Warn that the symptoms may worsen initially, day 3 or 7, before improving. Review the treatment of underlying problems, example migraine, chronic musculoskeletal pain. Consider specialist referral if taking strong opioids or recurrent failed attempts to stop medication overuse. Facial pain. Treat the cause. Common causes include trigeminal neuralgia, temporal mandibular joint disorders, dental disorders, sinusitis, migrainous neuralgia, shingles, post-herpetic neuralgia. No cause is found in many patients. It is then termed atypical facial pain. Atypical facial pain may respond to simple analgesia with paracetamol and NSAIDs. If this fails, so if there is a cause, it is typical, and if there is no cause is found, then it is atypical facial pain. May respond to simple analgesia with a paracetamol or NSAID. If this fails, try nerve painkillers like amitriptyline, 10 to 75 milligrams nocte. If troublesome symptoms are there for facial pain, refer to ENT, maxillofacial surgery, or neurology. Trigeminal neuralgia. Paroxysms means you will find that there will be recurrent episodes of intense stabbing, burning, or electric shock type pain, lasting seconds to minutes in the trigeminal nerve distribution. 96% is unilateral. Mandibular or maxillary more than the ophthalmic division. Between the attacks, there are no symptoms. Frequency of attacks ranges from hundreds per day to remissions lasting years. Pain may be provoked by movement of the face like talking, eating, laughing, or touching the skin like shaving or washing. So there will be a trigger factors. Can occur at any age but more common in more than 50 years. And females more than males, they say. Unknown cause but may be associated with multiple sclerosis in younger patients. Management of a trigeminal neuralgia, spontaneous remission may occur, and the drug of choice for treatment of trigeminal neuralgia pain is carbamazepine. Unlicensed indication, start a low dose 100 milligrams OD or BD and then increase the dose over the weeks until the symptoms are controlled. Usual dose is 200 to 400 milligrams twice a day. Often poorly tolerated. Oxcarbazepine is an alternative. If no response in less than 8 weeks, refer early for specialist assessment and advice on pain control. Refer to neurology if less than 50 years of age. Neurological deficit between the attacks. Treatment with carbamazepine or oxcarbazepine fails. Specialist options include other neuropathic painkillers like amitriptyline, gabapentin, pregabalin, duloxetine, lamotrigine, baclofen, phenytoin, or surgical intervention. So that is for trigeminal neuralgia. Raised intracranial pressure. Raised intracranial pressure or increased ICP usually presents with increasing headache associated with drowsiness, listlessness, vomiting, focal neurology, or seizures. Causes include primary or secondary tumors, could be a head injury, intracranial hemorrhage, hydrocephalus, meningitis, encephalitis, brain abscess, and cerebral edema, secondary to a tumor, trauma, infection, or ischemia. So, clinical features of raised intracranial pressure. If suspected, admit as an emergency. There will be drowsiness, dropping pulse, decrease in conscious level, raising BP, irritability. So, low pulse and raising BP and rising BP and decreasing conscious level, irritability, sixth nerve palsy, papilledema, focal neurological signs due to underlying pathology, pupillary changes, constriction, then dilatation. Benign intracranial hypertension. Symptoms or signs of space-occupying lesion, but none is found. Usually occurs in young obese women. Causes unknown. Treated with repeated lumbar punctures, ventriculoperitoneal shunt, diuretics or dexamethasone usually resolves but 10% recur later. Brain abscess may be single or multiple. Organisms reach the brain via the bloodstream and direct implantation or local extension from adjacent sites. So brain abscess, how do you get an abscess in the brain? So organism will reach via the bloodstream. Can be blood-borne or direct implantation or local extension from adjacent sites, like when you have a sinusitis might lead to brain abscess. Presence with an increased intracranial pressure, focal neurological signs, systemic effects of infection or local effects of due to the cause. Usually features develop over 2 to 3 weeks, occasionally more slowly. If immunosuppressed, onset is rapid. If you suspect, admit as an emergency. Treatment is with IV antibiotics and surgical drainage of the brain abscess. Mortality is 20 to 30%. 50% survivals have long-term neurological deficit. 30% have epilepsy. So this is an urgent referral case, brain abscess. Intracranial tumors. So, if any of the signs of raised intracranial pressures is present, like these: drowsiness, dropping pulse, decreased consciousness level, rising BP, irritability, focal neurological signs, pupillary changes, constriction, then dilatation, and papilledema, 6 nerve palsy. So, and then you have to think of any of these conditions and then do appropriate management. Intracranial tumors, primary tumors, classified whether benign or malignant cell type. Glioma is an umbrella term meaning of nervous system origin. Common subtypes: astrocytoma, oligodendroglioma, glioblastoma, multiforme, ependymoma. Tumors of the meninges like meningioma, cerebral blood vessels, cerebral hemangioblastoma can occur. Secondary tumors, 30%, usually from, so normally intracranial tumors are primary, more than 70%, and secondary are very less, 30%, usually from CA breast, lung, or melanoma. In 50% tumors, there are multiple brain tumors. Presentation: less than 1% with a headache have a brain tumor. So ICP, raised ICP is the most common presentation, 23 to 50%. They have papilledema at presentation, headache 25 to 35% cases, seizures 25 to 30% cases. Suspect all adults who have a first seizure, especially focal with localizing aura, refer for an urgent assessment for brain tumor. Evolving focal neurology depends on the site. More than 50% of focal neurology at presentation. Frontal lobe lesions tend to present late. False localizing signs caused by raised ICP. Sixth nerve palsy causing double vision is most common due to its long intracranial course. Subtle personality change, 16 to 20% at presentation. Irritability, lack of application, lack of initiative, socially inappropriate behavior is a personality change. When there is a sudden personality change in a person, you should suspect something going on in the brain. Local effects: skull base masses, proptosis, or epistaxis. Differential diagnosis of a brain tumor: stroke, could be stroke, multiple sclerosis, head injury, vasculitis, encephalitis, Todd's palsy, metabolic electrolyte disturbance, other causes of space-occupying lesion like abscess, subdural hematoma, or a cyst. So, these are the differential diagnosis for a brain tumor. Prognosis: gliomas all have 20% 5-year survival depending on the site. Meningioma, hemangioblastoma have better prognosis. So, all gliomas have only 20% survival, 5-year survival. Driving, informing the DVLA and seeking specialist advice. Referral guidelines for suspected brain tumor. Adults, if available, urgent direct access to brain MRI, CT scan if MRI is contraindicated, to be performed within less than 2 weeks. If progressive subacute loss of central neurological function, including unexplained personality change or cognitive deficit or intracranial nerve palsy. If direct access to MRI or CT is not available, refer to be reviewed by a neurologist in less than 2 weeks. So, you have to get a brain MRI or CT scan done before referring to a neurologist if you have access. Otherwise, you have to refer to neurologist in less than 2 weeks. Children and young people. In adults, that is that. In young people, very urgent specialist pediatric referral. You are not sending them for any MRI or imaging. You are to send them to a specialist pediatric referral within 48 hours, not 2 weeks. Newly abnormal cerebellar or other central neurological function is present. Other reasons to refer to neurological assessment: if there is papilledema, emergency referral; new onset seizures, emergency referral; unexplained transient loss of consciousness, urgent referral; new onset unexplained persistent headache in a patient with history of HIV or immunosuppression or cancer metastatizing to the brain. So this is definitely another brain tumor, so urgent referral. Progressive headache worsening over the weeks, especially if associated with vomiting, drowsiness, coughing, sneezing, exercise, urgent referral. Atypical migraine with aura, motor weakness, double vision, visual symptoms, just one eye, poor balance, decreased consciousness, urgent referral. Substantial change in quality of usual headaches, urgent referral. Persistent headache for more than 1 month or very frequent headaches affecting usual functioning, refer to soon or routine referral. Hydrocephalus is dilatation of the cerebral ventricles and accumulation of CSF. Could be communicating due to increased production or decreased reabsorption of CSF, cause post-meningitis or subarachnoid hemorrhage. 80% develop some kind of hydrocephalus. Trauma, neoplastic infiltration of the subarachnoid space. Non-communicating hydrocephalus. CSF flow is blocked due to an obstruction within the ventricles. Due to congenital malformations, tumor, brain abscess, subarachnoid hemorrhage, meningeal scarring due to meningitis or renal trauma. So presentation and management. In infants and children, page 878. In adults, present with increased intracranial pressure, refer for urgent neurological assessment. All patients with a CSF shunt should have a pneumococcal vaccination. This is an indication for pneumococcal vaccination. So there we are done for today. So tomorrow we will continue from page 534. That's all for today. Thank you. Have a good day.